Of course, next is the Bryant triangle. Bryant triangle is a triangle that is formed by this ASIS. Okay, just I have just shown how to draw the ASIS. This mark the ASIS. This one, the most prominent part of trochanter. Here we have 2 points: most prominent part of trochanter or greater trochanter, and the anterior superior iliac spine. Okay, in this, you draw first line from the ASIS perpendicular to the examination couch or the floor. Let's say this is the perpendicular to the floor. This is the first line drawn from ASIS. And the second line is you draw a line from the tip of the trochanter which is perpendicular to the first line, like this. We assume that this is perpendicular. Okay? And third line, of course, join these two, or hypotenuse. So this is the hypotenuse, this one is the base, and this one is the perpendicular. So this is ASIS, this is trochanter. So this is a Bryant triangle. Similarly, you can draw on the other side, and you measure each of the limb, like base, perpendicular, and hypotenuse, all of these three. You measure this. This is also one of the measurement, and you have to draw the Bryant triangle on both sides and compare. For drawing the Bryant triangle, there are some fallacies. Okay? Even for a measurement, this is also a true measurement. That's why, just like a true length of the lower limb, for drawing of the Bryant triangle, you also have to have a squaring of the pelvis. So there are a few fallacies, like if you cannot square the pelvis, like in fixed pelvic obliquity, if you cannot square the pelvis, you cannot draw a Bryant triangle, you cannot take the measure the true length. So first fallacy is when you cannot square the pelvis. Second is when both the sides are involved, both the hips are involved. In that position, the Bryant triangle base perpendicular hypotenuse will give only relative amount of shortening or lengthening, not true shortening or lengthening, like not true supratrochanteric shortening lengthening. It cannot say. You will just give relative lengthening or shortening. Other fallacy is when the bony landmark, like greater trochanter, tip of the trochanter, or the ASIS has been destroyed by some surgery, some infection, like that. When the bony landmarks are necessary, are not clearly palpable, it is a fallacious. Other is sometimes in the obese, fatty, obese people, the landmarks are not accurately localized. That is a fallacies for Bryant triangle. Remember, this Bryant triangle is a right angle triangle with a base, hypotenuse, and perpendicular. The first line is the perpendicular, second line is the base, and third is the hypotenuse. Similarly, I will draw here also. On the other side, the same procedure you have to repeat here. Okay, you draw the perpendicular here. Okay, you draw the base here, and is hypotenuse. Sorry. Okay, this is the hypotenuse. Okay, this point, this point, this point, and this should be a perpendicular. Okay, I will measure the base of the Bryant triangle here. So it is around 6 or 5. It is around 5, let's say. Okay, and this is around. So this is 6, let's say, and this is around, let's say, 7. This side, I'll measure around 3. Just 4.5, or let's say 5. Sorry, this 4.5 is, let's say, 4. 4. And this is, let's say, around 5, let's say. Sometimes in an obese patient, the measurement may not be accurate. There will be always like 5 millimeter or 10 millimeter of margin of error will be there because of, well, this is difficult in measuring that one. So this is a linear measurement, and next is the circumferential measurement. You measure the thigh and calf. As I said, you have to mention the apparent wasting of thigh and calf muscle on the attitude or inspection. Then you have to confirm that. How to do is you just make a joint, this middle joint line. Okay, you can take a equivalent point, let's say 15 centimeter above this one, this 15 centimeter above this one, and you're going to do 15 centimeter over this one. Take a comparable point, either 15, 15 or 20, 20, whatever it is, and you just take a circumference at that level. That's so how much wasting of this one. Almost it is 32, and here also it is. You see, this also almost 32. Though we have a normal boulder here, the circumference of the thigh is equal. Similarly for the calf, you can take one point, this is around 15 centimeter below here, and one point around say 15 here, and take a circumference over here. It is 25 here. So this it is 25. So both the calf circumference are equal and thigh circumference are equal. Okay. So this finishes the inspection, palpation, movement, and the measurement. After that, we have some special test. Special test is for and foremost is telescopy. Telescopy is a test for assessment of stability of the hip joint. Okay, when because of some pathological condition like infection or whatever it is, the hip may be unstable. So for that, what you have to do is you just flex the hip and knee to 90 degree like that. With one hand, you hold, support this and hold this like that, like this, the proximal leg, and thumb at the ASIS, and out of both these four fingers at the trochanter, and you just push and pull like that, and you feel whether the hip is the movement, the vertical excursion of the trochanter you feel. If his hip is unstable, on pushing down it may go out, and on pulling down it may come out. This is test for instability of the hip, vertical instability at 90 degree. That is push and pull. Sometimes the thigh is in obese person, the thigh is big. So what you have to do is you can hold like that and do like that, push and pull. This is the telescopy test in 90 degree of flexion. Some of the examiners would like to assess the stability of hip in extended position, like to keep like this and push and pull like that with knee fully extended like this. This is to test the stability of the hip in extended hip, and this is for stability of hip in flexion. Next is the axis deviation. And axis deviation means you try to hold the distal third of the leg with one limb, one hand, and you gradually loose. Ask the patient to relax, and gradually you flex the hip and knee, and see where the knee is pointing towards. Usually, if the joint is symmetrical, concentric, hip joint is there. By doing this, on flexion you are doing movement at one plane. On doing flexion, this should go towards in a single plane. This should point towards the shoulder. The knee should flex towards the shoulder because they are in the same axis. When the sphericity of a head is not maintained, like in Portis or a stiff upper femoral epiphysis or stiff capillary femoral epiphysis, on doing gradual flexion, instead of going the knee towards the shoulder, it go out like that. So you like this, you go like this. This is the axis deviation because the knee is going away from the shoulder, not towards shoulder. This is because when the sphericity of the head is not maintained, this is called positive axis deviation. So this is the positive axis deviation, and this is the negative axis deviation. The axis is correct. But when sphericity of head is not maintained, it just go out like that. Especially in SUFP or Portis like that. Or even adult with avian like that you may have. Next is the Galeazzi test. Galeazzi test determines whether there is shortening in the lower limb in the femoral component or tibial component. For that, you have to flex hip and knee. Flex the hip to around 45 degrees, knee to 9 degrees, both. Keep both the limbs together, both the lower limb together. Yes. So hip to be flexed at around 45 degrees, knee around 9 degrees. Make sure that both the heels are posteriorly heels are the same level. Okay. And if you see the level of the tibial tuberosity from this one, if one of the tibial tuberosity is lying lower, let's say this right side is at lower, is at lower level, okay. Or let's say posterior, I mean, let's say this is, instead of having level, same level, this is here up to here, anterior, this is posterior. One of them is anterior, one is posterior. Then it shows that there is shorting of the femoral component. When the femoral component is, this is short, let's say right side of femur is shortened, this will be anterior, this is posterior, this tibia is lying posterior. This shows the femoral shortening. If you see from this side, for whether one of the tibial tuberosity is anterior or posterior. If you see from top, if you see from here, you see the patella. If the one of the patella is at higher, let's say if here, this here, this is here, and the patella is at a higher level, let's say. This means that if one patella is a higher level, let's say this left side is a higher level, right is a lower level, then that shows that there is shortening of the tibial component. When tibia is shortened on right side, the patella is at low. Let's say, for example, like this. So this shows that this shows the tibia is shortened here. And this is like that. The tibia is shortened here on the right side. So this because this is at the lower level, this is at a higher level. Similarly, in this one, let's say if this is like this. For this part, see this part only. So this is lying posterior, this is anterior. This shows that there is femoral shortening. This is a Galeazzi test. Okay. So on a special test, other is transmitted movement. You try to roll the lower limb, keep your one hand over the trochanter and see whether the movement, the rotational movement of this lower limb is transmitted to the trochanter or not. This is also one of the tests you should see. Finally, you ask the patient to elevate the limb without flexing the knee. Like this. Yes. So this is the one of the way to see whether the hip or knee and ankle joints are intact or not. Yes, this way. Yes. This is to see dorsiflexion of the ankle and plantar ankle, to see the distal neurovascular neural status is intact or not. Similarly, you have to assess the opposite. Similarly, you have to assess the ipsilateral knee, ankle, contralateral hip, knee, ankle, and spine. We have to see all the spine, all this. So these are few special tests. There are some few measurements, special measurements which may be required in some special conditions. Out of them, one of them is the lateral line. You flex the hip, you keep the patient lateral position with the effective side up, and flex the hip and knee, hip to 90 degree. Like this. Hip to 90 degree. You can palpate the ischial tuberosity here. Yeah, somewhere around here. This is ischial tuberosity. Now, if you draw a line joining the ischial tuberosity and this ASIS here. You draw a line here joining the anterior superior iliac spine and the ischial tuberosity, these two lines. The tip of trochanter here, the tip of trochanter should lie either at that level or little bit below, but never proximal to this line. The tip of a trochanter lies at the line joining the ASIS and the ischial tuberosity. The line joining the ischial tuberosity and ASIS is known as lateral line. So if the tip of trochanter here, somewhere like this, if tip of trochanter is up, to this line, then you show that there is shortening, supratrochanter shortening. The trochanter has higher up, has gone higher, or there is shortening. This is important because this line is independent of other line. Even if the opposite side hip is abnormal, it doesn't make any difference in interpretation. This is independent of other hip. This is a Nelaton line. Next, make the patient supine. See that? Okay. Make the patient supine. Okay. You draw a line joining the tip of the trochanter and ASIS and project medially. Yes. You draw a line this and project medially. Of course, you have to have a scale to measure this line. Then you project a line here. Like this. Similarly, you will join a line, of the trochanter and the ASIS and project the line towards the trunk, like this. Actually, I should have used the scale, but I am not having right now. So you draw a line here. Okay. Now what you can see is these two lines. These are called shoemaker line. I write here shoemaker line. If you project this towards the midline, they will cross in the midline at the umbilicus, at or slightly higher umbilicus. That is okay. Slightly higher or proximal to umbilicus or at umbilicus, but not that. This is normal. When there is shortening, greater trochanter has tip of the trochanter is higher, is have up here. What will happen? This line will be somewhere like this. If the trochanter is at higher level, instead of here it is here, the line will be somewhere like this. Here, they will cross here. So when the trochanter is higher up, these two lines will cross below the umbilicus and on the other side. So this is crossing on the left side, that means the right trochanter is a higher level. This is below the umbilicus and on the left side. So the right side trochanter is higher up. This is a shoemaker line. Similarly, we can draw a few other lines. This is called Chinese lines, CHINES. You draw a line joining the ASIS of the both side. One line joining here. Similarly, you draw another line joining the tip of trochanter here. These two lines. Usually, basically, these two lines will be parallel. Let's say, suppose here, somewhere here, and here. This is trochanter line. You have to draw a complete line here, and the anterior superior LS line here, like this. Usually, these two lines will be parallel. Okay. When one of the trochanter is higher up, it proximally written, what will happen is they will be converging on the opposite side. If this is higher, these two instead of being parallel, they will be converge. They will converge to the opposite side. Okay. So Neraton line, shoemaker line, and Chinese test or Chinese line. And there is something called Morris bitrochanteric test. What you do is you keep a cardboard over here. It measure distance between the trochanter and the symphysis pubis here. You draw this, measure distance between these two lines, and similarly you measure distance between these two lines. They should be equal. In a central fracture dislocation, when head of the sternum has gone inside the pelvis, the trochanter is medially shifted, and this distance will be less in comparison to this one. Point to understand is whether this is Morris bitrochanteric test, Chinese line, or shoemaker line. All these three tests is a comparative test. The inference will be drawn in comparison to other side. So if the other side is also pathological or diseased, you cannot draw inference. However, the Neraton line that joins the ischial tuberosity to the ASIS is the line which is independent of the other hip. Even if the other hip is normal, you can draw a conclusion from the Neraton line. These are a few lines which is important for measurement point of view. Okay. Now finally, I would like to summarize how to summarize our findings on a tabular form after finishing this examination. Okay, now I would like to summarize our finding in a tabular form. How to write on this one? We can write is, let's say this is the right side and this is the left side. First start with the level of ASIS, the anterior superior iliac spine or ASIS. Let's say the ASIS on the right side is at lower level, or let's say this was on higher side. Let's say it is on left side, it is at higher level on the right side. We are considering our hypothetical case how to tabulate. After that, we have the flexion. Flexion on the left hip, we are assuming that the right side is a pathological one, and left side, of course, flexion is from, let's say, 0 to 140 degree, which was normal. In the flexion on the right side, let's say it is 10 to 140. Now see here, the range of motion on the right side is starting from 10, where it is 0 on left side. This is normal side. So this 10 to 140 implies that whenever range of motion on any side or for any axis doesn't start with 0, it signifies that there is some fixed deformity. This from 0 to 10 degree, whatever the initial 10 degree of the flexion has been lost. Now let's say in extension, for example, if extension is not possible on the right side, is dash not possible, it was, let's say, 0 to 20 degree on the other side. See here, the extension is not possible. However, the flexion was only from 10 to 140 instead of 0 to 140 on the normal side. The initial 10 degree loss of flexion here with no extension, that is opposite movement, that is extension is not possible, and the hip is fixed in 10 degree of flexion, beyond which you cannot extend, but you can flex from 10 to 140. This means that there is 10 degree of fixed flexion deformity with further range of motion from 10 degree to 140 degree. Sometimes it may be associated with pain, crepitus, or spasm like that. You can mention here if it is associated with pain, you just write pain here. Flexion and extension in the sagittal axis. Now next is the coronal axis, sagittal axis plane. Next is coronal plane. We talk about the abduction and adduction here. For any case, let's say the adduction was from 10 to 40 degree, and here it is from it is from 0 to 50 degree. Let's say abduction is not possible. The abduction is from 0 to 50 degree. Similarly, now see here, the adduction is from 10 to 40 degree on this right side. However, abduction is not possible. This still again implies that there is fixed 10 degree of adduction deformity. Why fixed? Because opposite movement, that is the abduction, is not possible here. So this implies that there is 10 degree of fixed adduction deformity with further range of motion from 10 to 40 degree. And of course, abduction is not possible here. Next is the external rotation. ER external rotation. We have assessed the external rotation of the hip in flexed hip and extended hip. So you can write ER in extended hip. The EXT means in extended position. This is in flexed position. Similarly, internal rotation in extended hip and flexed hip. Okay. Let's say for a patient, the internal rotation is in extension is from 10 to 40 degree. And flexion also 10 to 40 degree. Here it is 0 to 50 degree and 0 to 50 like that. 0 to 50. I am only giving an hypothetical example how to tabulate the patient, tabulate the finding of a patient. Okay. Sorry. Let's say this is not possible for this side, and this is 0 to 40 degree. So if I write this, there is fixed internal rotation deformity of 10 degree with further range of motion from 10 to 40 degree, and the external rotation, that is opposite movement, is not possible here. Now next is apparent length. Okay, apparent length is a measurement of limb with both the limbs parallel to each other and parallel to trunk. Okay. The patient may have been compensated, may not have compensated for this, depending upon the deformities and amount of lending and sorting, whatever it is. Okay. Let's say it is 102 and is 104. The number 102 and 104 centimeter is not so significant until you are able to say that there is 2 centimeter of apparent sorting on right side. Apparent sorting 2 centimeter. It appears, maybe true, may not true. Next is we have measured a true length. Okay, let's say this is 87 centimeter and this is 86. Again here the number like 86 and 87 are not so significant. What is significant is there is really a 1 centimeter of true sorting of 1 centimeter on the right side. So this is true length. For true length, I again repeat, you have to measure true length with pelvis square, that is both the ASI are at the same level and both the limbs to be in identical position. Pelvis should be square and both the limbs to be in identical position. Next we have measured the thigh circumference and calf circumference. In a prolonged cases of hip pathology, you may have expect the thigh and calf twisting also. Let's say this is 24 and this is 26 and this is 15 and this is 16. Let's say. Finally, we have drawn a Bryant's triangle also here. You can write Bryant's triangle here. Okay. Bryant's triangle, say this is for right side. Patient is right side is here. Here was the great trochanter. Here was the ASIS, and here is this is ASIS. This is ASIS. This is greater trochanter. Or I can write like this. First line is perpendicular from ASIS. Second line is a perpendicular line from greater trochanter to the first line, and third is hypotenuse, like that. Similarly here you can draw like that. This ASIS, this is greater trochanter and perpendicular. Let's say this is 3, this is 4 and this is 5. Okay. Or let's say it was around a little bit higher, with a 4, 5 and 6. Let's say this was 3, this was 4, this was 5. The base of Bryant's triangle is 3 here, is 4 here. This is only a hypothetical example I am showing. This is how you tabulate. Now next is see the Bryant's triangle here. The base of Bryant's triangle was 3 cm on right side and 4 cm on the left side. This base of the Bryant's triangle, that denotes the true supratrochanteric shortening. You can see there is 1 cm of true shortening was there in the right side, right lower limb. It may arise from the femur and tibia, and our femur is maybe from supratrochanteric or infratrochanteric. So as you can see that shortening of 1 cm in the base of the Bryant's triangle, that shows that there is 1 cm of true shortening, that is supratrochanteric. That means physically or anatomically there is really there is shortening by 1 cm in the Bryant's triangle arising from the area proximal to the trochanter, maybe from the neck of femur or maybe hip joint. Okay, so 1 cm truly the limb was 1 cm shortened. Now next come to adduction or abduction. See here there is 10 degree of fixed adduction deformity on the right side. The adduction deformity will lead to shortening, the abduction deformity will lead to lengthening. And roughly 10 degree is equivalent to 1 cm. So the adduction of 10 degree will lead to shortening of 1 cm. That is functional shortening. So here really the right side lower limb and supratrochanteric region it was shortened by 1 cm. Because of this adduction deformity, again 10 degree of adduction deformity has added up to 1 cm shortening. So total in apparent it appears that the limb is 2 cm shortening. 1 cm anatomical shortening and 1 cm because of this adduction deformity. The same you see here apparent length it is 104 is 102. So 2 cm shortening is there, is apparent. Though the limb appears that it is 2 cm shortening, in actually it was 1 cm shortening and 1 because of this adduction deformity. This is how you can calculate for this. In this example, I have given an hypothetical example. You see this, there is a flexion deformity, that is fixed flexion deformity of 10 degree. In adduction abduction axis, you have 10 degree of fixed adduction deformity. Similarly, internal rotation and external rotation axis, you have a 10 degree of fixed internal rotation deformity, and there is true shortening by 1 centimeter. Let's say this one. So the combination of deformity is the flexion one, the adduction, internal rotation, and true shortening. So flexion, adduction, internal rotation, and true shortening. This is flexion, then adduction, and internal rotation, and shortening, that is true shortening of 1 centimeter. So this deformity is basically FADIR, flexion, adduction, internal rotation deformity with shortening. There are so many DD for different diagnoses of flexion, adduction, internal rotation. One of them common is stage 2 tuberous of hip joint, or maybe posterior dislocation of hip, like that. So depending upon these, you can make your difference diagnosis and proceed with so on. Basically, there are various combinations of different, like flexion, adduction, internal rotation deformity, flexion, abduction, and external rotation deformities. Sometimes you may also have flexion, adduction, and external deformities. Basically, these are 3 broad classes of deformities you have in the hip joint. Depending upon this finding, you can get your difference diagnosis and proceed accordingly. Okay, I would like to stop here and thank you for watching.